Our speaker today is Dr. Lainie Ross, who will speak on the topic of pediatric transplantation, donors, and recipients. Dr. Ross needs no introduction, but that doesn't mean I won't give you one. Dr. Ross is the Carolyn and Matthew Bucksbaum Professor, the Associate Director of the McLean Center, and a Professor in Pediatrics, Medicine, Surgery, and in the college. Dr. Ross also serves as the co-director of the Institute of Translational Medicine here at the university. Her training was medical school at the University of Pennsylvania, residency at CHOP in Columbia, and then she wrote her PhD at Yale, PhD in philosophy at the University of Chicago. Many of you have worked with Dr. Ross, and you know her extraordinary capabilities as a mentor and teacher. She serves on the Secretary's Advisory Committee on Human Research Protection and on the American Academy of Pediatrics section on Bioethics Executive Committee as its chair. It's a great delight to invite and welcome Lainie to give today's talk.
Thank you. Thank you very much. So I wanted to begin with two things. First, to acknowledge the two students and Dr. Thistlethwaite who worked with me on this project. I don't know if Chris or Will were able to get out of their clinical responsibilities. And I wanted to start, though, with a question. So in kidney transplantation, are there more pediatric recipients or pediatric donors? So how many of you think that kids, in a sense, take more than they give, or do they give more than they take? So how many think there are more pediatric recipients? And how many think there are more pediatric donors? So we're sort of evenly split. And here's the answer. In 2011, there were 843 pediatric deceased donor kidneys, making up 11% of all deceased donors. There were 454 pediatric deceased kidney recipients, making up 4% of recipients. Hence, the reason to discuss pediatric deceased donor allocation issues from both perspectives. Just for those interested, there were 0 pediatric living kidney donors. That has not always been the case. And there were 302 children who received kidneys from living donors. So here are my 4 objectives: to discuss the policy issues raised by giving minors special priority in deceased donor solid organ transplants, and then to discuss the ethical and policy issues related to elective deceased donor transplants in minors. And then with regards to pediatric solid organ donors, I'm going to really talk about allocation issues with pediatric deceased donor organs. I doubt we're going to have time for me to talk about the whole issue of whether children should ever serve as solid living organ donors. So I'm probably just going to focus on these 3. So let me begin first with pediatric recipients. So the first question is, should children be given priority for deceased donors, and then priority for early allocation and priority for the best quality organs? And so a policy was written in October 2005 that UNOS implemented, which basically said that all renal allografts from young deceased donors less than 35 years of age would be given preferentially to local pediatric patients less than 18 years. Although if a local suitable pediatric candidate couldn't be found, the organ would be offered to a local adult candidate. And the policy was intended to reduce waiting times for pediatric candidates and allocating ideal deceased donor kidneys to them. Now, I should begin with my real bias, right? I'm a pediatrician, so I'm always wanting to get the best for kids. So clearly, I was in favor of a policy that was going to do that. And there are actually clinical reasons to justify my bias. One is that children don't grow and develop appropriately on dialysis, so that if they're in chronic renal failure, they really do need kidney transplant. But why 35? Why did they pick the age of any deceased donor under the age of 35? And here I have a graph which shows you that the quality of kidneys from donors over the age of 35 are much, have a worse graft survival as time goes on, and clearly kids are going to need kidneys that are going to last for decades. And so it makes sense to give them kidneys that are going to last as long as possible, so that we don't have to start talking about retransplanting them in their 20s, but maybe in their 30s or 40s. I also just wanted to point out the impact of Share 35. So before we had this rule, what you saw was that kids were getting kidneys from everywhere. And in fact, if you just look under the beige, so up to here, they were getting what we now call ideal donors, but they were actually getting a large number of kidneys from people 35 to 49, and even some of the older donors from 50 and up. And now, under the new policy, you notice two things. One is they got more kidneys in the same 5-year time period, but also that virtually all of the kidneys they got were from donors under the age of 35. The yellow representing a small number of deceased donors from 35 to 49-year-olds. And these may be individuals, for example, who had high sensitization and therefore weren't able to match easily to a kidney. So the policy did what it wanted. It gave the best kidneys, and it gave more kidneys to children. And here, in fact, if you look, is another way of seeing this data. And what we did here was look at time from waitlist registration. And again, if you look, you're going to see two things. So 2002 was just a year we picked that was going to be pre-Share 35, and 2007 post-Share 35. And what you will see is that within 6 months after Share 45, only 43% of the children who had been waitlisted were still waiting, and that it was down to only a quarter by 1 year, versus there was still a third waiting for kidneys pre-Share 35. So again, they were getting them more quickly. Well, you're also going to notice one other change, though, which is that here, when you see where they got kidneys from, the children in 2002 got 301 of their kidneys in the first 6 months from deceased donors, and got 83, or about a quarter of them, from living donors. And here in 2007, they got 278 transplants and 86 from living donors. But overall, in the end, for the living donors in 2007, they look like the same. They're actually pretty equivalent in the number of numbers. So not too much of a fall in 2007 in the number of living donors. But I also wanted to show, though, some of the unintended consequences of Share 35. And there is actually a relative drop in the number of parents who continue to donate to their children. And in part, you might say, why is this? And the answer is, if I'm promised a great deceased donor within 1 year, I might as well save my kidney for when my child needs to be retransplanted. This was not anticipated at the time of writing the deceased donor policy for Share 35. And why this becomes a problem is because there are two concerns. One, if kids are taking more deceased donor kidneys and taking the best kidneys, then as there's less kidneys for adults, then adults are going to have to start looking for living donors. And in a sense, if you ask me, would I rather a 15-year-old get a living donor or a 65-year-old get a living donor, the answer is clearly I want the 15-year-old, because again, those are the ideal donors. They're going to last even longer than the best deceased donor, and so it'll reduce the need for retransplant. But from a parent's perspective, you can see why they might go the opposite way and think to themselves, when they need a retransplant, they're not going to have priority, so let me save my kidney for that time. And that's what happened. And this is important because as we're talking about new kidney allocation policies currently in the United States, there's this move to give the best kidneys, not just to kids under 18, but to really give some of the best kidneys to even young adults up to 30 or 35. And what that might do is decrease the number of living donors overall. 75% of all transplants in young adults under the age of 30 come from living donors. And so either we're going to have less overall number of kidneys because the living donors are going to stop donating, or we're going to be transferring those living donors to older people who might not otherwise get a deceased donor, and that would be quite inefficient. But one question is it working? In the sense, are their grafts surviving as long as we had hoped? And I just want to point out this one piece of data which shows that the 1 year and 5 year allograft survival among recipients of kidney transplants from ideal donors. And what you're going to see here is that the number of grafts functioning at 5 years really plummets in that adolescent to young adult group. So as we give them better kidneys, they're not doing so well with it. And the reason is because they are the least compliant with their immunosuppression. And so, in a sense, are we really getting the efficiency that was hoped for? And in fact, in this article by Levine et al., this is the quote: "The allocation of ideal donors to adolescent recipients may not maximize graft utility. Reevaluation of pediatric allocation priority may offer opportunities to optimize ideal renal allograft survival." So there's at least some people who are trying to push back on the grounds of poor compliance. Again, my bias being a pediatrician is that clearly I support Chair 35, but I think we have to acknowledge some of the issues and acknowledge the unintended consequences of reducing living donors. And part of this is we have to remember that UNOS controls, allocates deceased donors, but in a sense, as a living donor, you get to choose who you're going to give to. And so the more we give priority to young, both children but also young adults of living donors, we may actually reduce the number of living donors overall. Or change it to be giving it to older people who really don't need a kidney that will last them for 25 or 30 years. So as I said, the point of this whole part was to really think about the unintended consequences, that as we give all these donors, we're going to decrease the number of living donors. The next part of the talk, then, is to look at something that very few people think about, which is this notion of elective organ transplantation in children. So what is an elective transplant? It's the practice of offering an organ transplant when an alternative procedure exists. And there are two good examples in the literature. One is hypoplastic left heart, where children can undergo a 3-stage Norwood procedure, and the other, or they can get a heart transplant. And the data, mostly from Alex Kahn, shows that people are offered usually one or the other, depending on the site where their child happens to be born and diagnosed. And yet their results in morbidity and mortality are actually quite similar. Another place where we have elective transplants, and the one I want to talk about today, is in liver transplant, where some children with metabolic conditions, for example, maple syrup urine disease, they can be treated by dietary means or liver transplant. The problem with the dietary means is that if they have an event, it can be quite catastrophic from which they may not recover, particularly cognitively. And so in some ways, the liver transplant reduces the fear of a protein overload in these children. And this is going to become a bigger and bigger issue as we continue to expand newborn screening, because we're going to be picking up more children asymptomatically with some of these conditions who may be, in a sense, the ideal transplant candidate. So the procedure is elective, and we can debate whether we're talking about in hypoplastic left heart or maple syrup urine disease, whether the alternative treatment or the transplant is better. But the point of calling it elective is that there are some children who need a heart transplant or a liver transplant who don't have an alternative, right? So they're going to die on the wait list while we're going to give some priority to these children, and we need to ask ourselves, is this fair? And as I pointed out, though, at this point, Norwood's equivalent. The data are still coming in about which is better from an individual child's perspective, a liver transplant or dietary treatment for maple syrup urine disease. So traditionally, this is the way we treated children with maple syrup urine disease in order to preserve normal function of the CNS. In an ill newborn, ECMO may be necessary, and then lifelong dietary restrictions to maintain blood metabolic concentrations close to normal. And throughout life, there's aggressive interventions every time they have an illness in order to rapidly reverse any metabolic derangements. But the real concern then is that these kids can stroke out if not aggressive enough. And so despite aggressive treatment, despite knowing how to take care of these kids, many kids with classic maple syrup urine disease have a poor intellectual outcome, sometimes because of delay in diagnosis, sometimes delay in starting treatment, sometimes because of acute metabolic derangements, and that their metabolic control tends to deteriorate with age. So what are the outcomes with liver transplant and maple syrup urine disease? It's interesting that the first report actually was done sort of accidentally. So there was a 7.5-year-old French gypsy girl with maple syrup urine disease and terminal liver failure caused by hepatitis A viral infection. And she got a liver transplant and but both did quite well from the hepatitis perspective, but also, in a sense, cured her maple syrup urine disease. And after that, there was another decision then made to actually transplant a 2-year-old Spanish boy who had frequent metabolic decompensations. And in 1997, there was a 2-year-old girl here in the United States who had a vitamin A intoxication. Her parents had given her an overdose of vitamin A, thinking this would help treat her liver problems. And so, again, not only reversing the vitamin A problems, but also curing maple syrup urine disease. And it was because of several of these case studies that Strauss et al. At the special clinic in the Amish community out in Pennsylvania worked with the Children's Hospital of Pittsburgh to actually put these children on the liver transplant wait list at the Children's Hospital of Pittsburgh. And they were able to actually argue for high prioritization due to the neurologic burden of the disease, particularly if there's decompensation. And as one would imagine, is that patients with hepatic-based metabolic disorders will do really well with a liver transplant. One, it reduces their acute metabolic decompensation, but it's also that they're very healthy in general when they go into having the liver transplant. So at the Clinic for Special Children, as I mentioned, they did it, and they actually looked at it from a cost perspective, because this is the Amish community which doesn't have health insurance but pays in cash for their health care, and they came to realize that it was actually financial, not only just from a medical perspective, but they also thought that economically it was saving in order to have a liver transplant. And part of their argument about that was they looked at the number of hospitalizations for acute metabolic decompensations for their children. So what's the obstacle to performing liver transplants in all patients with maple syrup urine disease? And part of the issue is going to be the scarcity, and the fact is that they have an alternative treatment, and we're going to have to ask ourselves whether it makes sense to be giving people transplants when they have another alternative. I point this out because the year 2001 has two interesting facts that happen. One is, and this is for all living donor liver transplants for both adults and children, and you'll see that in 2001 we have 524 living donors, and the numbers in a sense decreased thereafter and have still haven't recovered and probably never will. And you'll also notice that in 2001 we peaked in the number of deaths, and the number of deaths have been going down since 2001. And there are two facts that happened in the year 2001. The first was the death of a living donor, Mike Hurwitz, which really put a damper on the whole issue of doing adult-to-adult living donor. The reason for the decrease in the wait list was also a change in the liver allocation policy into something called MELD and PELD. And as you can see, it's actually been quite effective, even though the number of livers that are available really hasn't changed over the time, the number dying on the wait list. Nevertheless, people with metabolic disease would have very low PELD scores and so wouldn't be eligible, and yet there are reasons that you can go to a region to ask for exceptions, and metabolic diseases have been considered one of those exceptions, so that they would be eligible for rather high priority in giving a liver transplant. So looking at the UNOS data, looking at who gets a deceased donor liver transplant, what you can see is, just to give you an idea from data from last month, is that the total being waitlisted for children under the age of 1 is only 38 children, and actually a pretty small number overall for all children. You can see that the number of children who received deceased donor liver transplants in 2012, a pretty large number. The number who received living donor transplants, and again, as I said, actually, it's smaller than I would have thought. So only 40 of the transplants of living donor were pediatrics. But you could also see the total number who died in 2012 while waiting on the liver transplant. So it's this group, in a sense, that there are 12 dying on the transplant, and if we're going to have a dozen or so children every year born with maple syrup urine disease around the country, the question is, should they get priority when other children are dying on the wait list? But so you have this issue, because from the particular child's perspective, it's probably better to get a transplant than dietary management, although, as I said, the data aren't fully in yet. And in our Western bioethics approach, we think of it as our obligation to the individual patient, which would then suggest that we should be offering liver transplants to these individuals, and that if offered, it will probably be accepted. But one could imagine a community deciding, you know what, there is an alternative, and the alternative is dietary, and basically saying that we're not going to be transplanting children with metabolic conditions unless, in a sense, they have a living donor. I actually don't support that, but I do think we need to think about what our policies are going to look like as we increase the number of metabolic conditions that we're going to be identifying in early childhood through newborn screening, that this issue is not going to get smaller, but it's going to grow, and it's going to require that UNOS come up with policies about thinking what type of priority, if any, that they want to give these children. So those are two issues about children being organ recipients. I now want to look at pediatric donors. Depending on the time, I'm probably only going to focus on children as deceased donors, but if there's time, we can also talk about when, if ever, should children serve as living donors. So starting with allocating pediatric deceased donor kidneys. So currently, as I showed, it represents over 10% of the total supply of U.S. deceased donor kidneys. 90% of pediatric donor kidneys actually go into adult recipients. The majority are aged 35 to 49. And in fact, a third of these kidneys are transplanted into adults over the age of 50. So pediatric deceased donor kidneys are actually quite important. And so one question is this a good use of pediatric deceased donor kidneys? Does it make sense to be putting in these small kidneys into larger individuals? So just to give you an idea, giving you a graph from over 10 years data, and I see Will Parker made it, and he's the one who actually made this graph. What you can see is then, so these are all pediatric kidneys from different ages, 0, 1 to 5. This means single kidney transplant. These mean en bloc, and we'll be talking about that. So this is giving to an adult a single kidney from a 1 to 5-year-old versus giving them both kidneys from the same donor, 6 to 9 and 10 to 17-year-old. And as you can see, there are a lot of pediatric kidneys being transplanted into adults, with the majority in the 35 to 49-year-old range. So fact one, all pediatric kidneys are not the same, and what I want to focus on for right now is the case of the very young donor, so those less than or equal to 5 years of age. And here is an important graph which shows looking just at 1, 2, and 3-year-old kidneys and their graft survival over time versus the 0-year-old kidneys. So clearly the 1, 2, and 3-year-olds do pretty similarly and do much better than a kidney from a donor less than the age of 1 year. The next fact is that very young donors, as I've mentioned, can either be allocated as single kidneys or en bloc. And as you can see, here is donors up to the age of 5. And the green is the number of kidneys that are transplanted en bloc, and the purple are the number that are transplanted as a single kidney. And so as we get older and as their children's weight get higher, you see that it becomes more common to do a single kidney transplant. But does it make sense to be doing all of these kidneys as an en bloc procedure? And so here's our data looking at, again, with the 0 kidneys doing worse. But what you can see here is that the 10 to 17-year-old kidneys, which are really considered ideal kidneys, they look sort of like the 18 to 35-year-old, those ideal deceased donor kidneys. What you see is the 1 to 5-year-old en bloc kidneys have a little bit of a problem right at the start in working, but once they start working, their long-term outcomes are as good as a 10 to 17-year-old kidney. And compare that, though, to the single kidney, which does approximately 10 percentage points worse over 5 years. But here's the problem. So I acknowledge that given the choice, everybody would want a 1 to 5-year-old en bloc kidney. But if we can save 2 lives, with the first life having just a 10% lower 5-year survival, does it make sense to be giving both kidneys to one individual, or should we be splitting them always? And we'll ignore the under 1 age kidneys because en bloc and single, they do much poorer than all the others. So historically, we think that it's important not just to look at how do 1 to 5-year-old kidneys do, but to really look at the difference between en bloc versus single, because those en bloc kidneys really do as well as the ideal donors, and to actually split out the zeros, because when transplant surgeons see the data from young children under the age of 5, it looks much worse because you're adding on those 0-year-old donors who we know are actually quite different than all the other deceased donors under the age of 5. And so here it compares all the pediatric kidneys again to the ideal adult donors, and what you see is here is the pediatric kidneys, and here is, why am I not seeing my 18 to 34-year-old donors? Because the lines totally overlap. So this is actually where you find the 18 to 34-year-old donors and the 10 to 17-year-old donors. And again, the 1 to 5-year-old is slightly worse. And as you can see, here are some of the pediatric kidneys. They actually do a lot better than the 50 to 59-year-old and the 60-plus donors. And the 35 to 49-year-olds doing as well as all of the other pediatric kidneys, including the 35 to 49-year-old donors, which is the red, looking quite similar to the green line, which are those single kidneys from 1 to 5-year-olds. So really questioning whether we can justify giving these kidneys out en bloc. So, so by allocating kidneys from donors age 1 to 5 en bloc, the total life years gained by the system goes down, right? They have somewhere between, as I said, a 7 to 10% decreased 5-year survival overall. So one question is, well, with Share 35, shouldn't we just give all pediatric recipients en bloc kidneys from donors less than the age of 5 years? And one of the things you saw from the data is most pediatric donors do not go to pediatric recipients. And so given that, since we're giving lots of adult 35 to 49-year-old kidneys and these single 1 to 5-year-old kidneys look the same, it might make sense for us to be dividing many more of them and at least increasing the number of transplants that can be done. In fact, of the 1,122 en bloc kidneys done over the decade, only 52 of them went to pediatric recipients. Now, the 0-year-old kidneys do much poorer, and so I don't think the arguments about en bloc and single really hold for them. Currently, the decision on how to procure kidneys, so how you take it out of a deceased donor, is left to the transplant team. In Eurotransplant, it's required, for example, that procurement occurs en bloc for donors under the age of 2. For donors between the ages of 2 and 5, it can be recommended that procurement occurs en bloc. That doesn't say how it's allocated. Even if it's procured en bloc, you can still allocate them singly. But it may be better to determine allocation as single kidney transplants versus en bloc based on weight rather than age is one concern, but also just the whole concern of whether it makes sense to be doing en blocs at all. Fact 3 about deceased donor kidneys is that these donors less than 1 year are virtually all transplanted en bloc, and yet they still do substantially worse, right? And so part of their problem is really that they just have a high 100-day risk of graft failure. But ultimately, they start to perform as well as organs from candidates over the age of 50, which compares in the kidney world to those kidneys that are currently labeled extended criteria donors. And in fact, this is a comparative graph which looks at just the 100-day survival. And as you can see, the ideal donors, which are 18 to 34, and that the 10 to 17-year-olds look exactly the same, both at 100 days and at 5-year survival. Those 1 to 5 en blocs, 2% lower in the first 100 days, so they have a slightly increased graft failure right at the beginning, but look exactly the same at 5 years. And so they might be almost too good to be giving out en bloc, right? Then when you look at the other children, slightly poorer in their 5-year survival compared to the ideal kidneys. The 1 to 5 single kidney, again, slightly poorer first 100 days, but looking just like a 35 to 49-year-old kidney donor. And most people would think that's a pretty good deal if they got a 35 to 49-year-old healthy deceased donor. With the 0-year-olds looking more like their older compatriots from the age of 50 and 60 plus. So this is the interesting thing, which is it depends what type of better you are. Because so the dotted gray line is the 50 to 59-year-olds, which clearly do better than either the 0-year-old donors, for at least at the beginning, and clearly do better than the 60-year-old donors. But the betting question is, right, so they do really poorly in the first 100 days, but after that, they're actually better than many of our extended criteria donors. So the question would be, you know, now knowing the data, if offered, and if offered, and particularly the typical individual accepting an extended criteria donor is going to be someone over the age of 60, which do you take? Do you bet on the short-term issues, or do you go for the long-term? And so I think it actually raises some interesting issues that haven't yet been addressed in the literature. So just food for thought. Which would you prefer, given the fact that you know that you'll have a bigger risk up front if you take the 0-year-old kidney, but in the long term it may turn out to be better. So to conclude, for this part of the talk, Share 35 refers to all kidneys from donors younger than 35 years of age. But what the transplant surgeon needs to know, and they already know, that 0-year-old kidneys have a high risk of early failure, and there are very few programs that probably accept a 0-year-old kidney. And yet we may need to be rethinking that, particularly for recipients who are older. The 1 to 5 block performs similarly to the best adult kidneys, probably should be split to maximize the number of candidates who receive kidneys. And then if split, the surgeon should consider, though, whether they want to use it as a minor, because all of a sudden those kidneys are no longer as good as the most ideal kidneys, but more similar to the 35 to 49-year-old, and we might want to leave those kidneys to the adults. I did tell you I had a pediatric bias. And finally, that allocation that assumes that kidney function improves linearly over the pediatric age ranges are wrong. There's a lot of assumptions that UNOS, as they're trying to design these new allocation systems, that pediatric kidneys are linearly improved. And I think what we've shown, first of all, is that en bloc does a lot better than single kidneys, number one. But number two, that the zeros are so much worse that they often weigh down if you include them in the 0 to 5-year-old block. So the minor is a transplant recipient. Clearly, I think that minors get and should get priority in deceased organ transplants. But we need to acknowledge the unintended consequences of this policy, and we need to figure out how to improve compliance so that they really are useful. And we also need to develop better guidelines and be realistic about these elective transplants, as they are going to increase over time. So we should all be willing to serve, clearly, the minor as a transplant deceased donor. We all should be willing to serve as deceased organ donors, or our parents should be willing to give permission for us to serve if we're minors. Who should be living donors? I threatened was going to be a separate talk, but given that I'm a New Yorker and talk so quickly, I'm actually going to be able to cover it, and I'm glad. So I'm going to skip over 2 slides, my conclusions, and keep going. The data about the quality of pediatric donors, though, needs further evaluation, and Dick, Will, and Chris and I are working on some papers in this regard, and it may change what we mean by Share 35. It may require guidelines about what kidneys should be allocated en bloc. But as I always say, as I'm trying to conclude, I'd be remiss if I did not mention that prevention of kidney disease actually must begin in childhood, right? Our obesity epidemic is just waiting to happen as these adults go into kidney failure. So we need to reduce obesity. We need to do better control of our children in diabetes and high blood pressure. So I'm going to skip that I claimed that I was going to end. And I'm going to go to the 4th point, which is, do children serve as living donors, and should they? So the fact is in the last 15 years, at least 60 children have served as living donors. In 2005, the Amsterdam Consensus Panel said, no, they never should. A statement in the U.S. in 2000 actually said yes under certain conditions. And the UNOS policy, under developments in 2008, said that age less than 18 is a relative contraindication, but did not exclude it totally. Now, the data I showed 0 donors from this past year. If you look actually in 2012, there's at least 1 minor who donated a kidney as a living donor. And so I was asked by the American Academy of Pediatrics to write a statement on giving guidelines of when, if ever, should minors serve as living donors. And this statement was written by the AAP Committee on Bioethics, with both Dick Thistlethwaite and myself as the lead authors. So it's important because we actually based most of our recommendations on the U.S. Live Organ Donor Consensus Group from 2000. And they had 4 recommendations: that the donor and recipient are both highly likely to benefit, that it didn't make sense to be letting a child serve as a living donor unless you thought that the recipient had a high likelihood of doing well. They also wanted to make sure that the surgical risk for the donor is extremely low. So I think what we're really talking about is children serving as kidney donors, although, again, if you look internationally at the data, children have served not only as kidney donors, but they have served as living liver donors. They have served as intestinal donors. The 3rd point was that all other deceased and living donor options have been exhausted. So we shouldn't be looking at children to serve as kidney donors if they have healthy enough parents or healthy enough other first-degree type relatives. And there was an importance to at least give the child some degree of assent to donate without coercion, and here it was recommended at the time to have an independent advocate. Living donor advocates have become commonplace now for both pediatric and adult, but at that time, in 2000, this was not a very common practice. For the AAP, we added a fifth criteria, which were not only to focus on that the surgical risks be low, but that the emotional and psychological risks to the donor not only be low, but also be minimized. The data that we were looking at to think about this point really came from the bone marrow transplant literature. And that literature where minors frequently serve as stem cell donors to siblings, in part because they have the greatest likelihood of being 100% histocompatible. The data there are somewhat or sometimes distressing, particularly when a recipient does poorly, that many children blame themselves rather than understand that it was their sibling's illness for which the recipient died. So the interesting thing is, one question is, should we allow living donor transplant between identical twins? Right? Because genetically the same, and the big benefit there is you don't need immunosuppression. And so people ask questions about the emotional closeness, and the data go in both directions. Sometimes identical twins are the best of friends, and sometimes they actually hate each other, right? But this is the big significant benefit is the immunological benefit. And so one question, though, isn't to just look at the benefit. Given that all the guidelines are focusing on minimizing surgical risk, minimizing psychological and emotional risk, the question is, to the extent that we believe that being a living donor as a child may put you at long-term health risks, should we allow greater risk-taking between identical twins? And as I say, some just do it as a cost-benefit analysis and say, well, the benefit's greater, so the risk can be greater. And some say no, because the risk to the donor remain the same. So the question was, should this allow for donors at younger age? And Dick and I were very much against it, but I should tell you that the American Academy of Pediatrics Board of Directors wanted us to treat identical twins differently. They felt that there was such a big immunological benefit that we should be allowing transplants between identical twins. So one of the ways of dealing with the board was to get a student involved and do a study. So this was a study done with Josh Joseph, who's now an emergency medicine doctor at Mass General. And what we did was we looked at 400 members of the American Society of Transplant and the 160 members of the American Academy of Pediatrics, just because of the small sizes of these groups. There were 80 members in the section on bioethics and 80 members in the section on nephrology. And we gave them a survey where we asked them about 15-year-old twins, one of whom has recently developed acute glomerulonephritis, has begun dialysis, and needs a kidney transplant. The physicians were told that the patient had been placed on the deceased donor wait list and would likely receive a kidney within the year due to her age. The physicians were also told that her parents, who are both diabetic, had inquired about serving as living donors but were ruled ineligible, and that in response, her healthy twin asked whether she could serve as a living donor. And so we gave a couple of scenarios. Was donation by the twin sibling appropriate in this scenario? Would donation by the twin sibling be appropriate if the wait for deceased donor was 6 years rather than 1 year? Would donation by the twin sibling be appropriate if the twins were 10 rather than 15? Did it matter whether the twins were fraternal or identical? And what if these were your own children? So those are the questions that the docs were going to be asked. 560 surveys were distributed. 49 physicians were excluded because they couldn't be located. Another 75 excluded themselves, saying that they either weren't practicing or these questions were outside of their area of expertise. So of the remaining 436 recipients, we had a 39% response rate. And what you see, actually, is that there was a 37% response rate by the American Society of Transplant, a 43% response rate by the members of the American Academy of Pediatrics. And here were our data. And in part, we're not going to get a lot of statistical significance due to the small size, but what you can see is that overall, looking at fraternal twins to looking at identical twins, the numbers go up approximately 8 to 10% for every question, whether it's about a 1 year wait or a 1 year wait in a fraternal versus a 1 year wait in identical, whether there's a 6 year wait, and it continues to go up. And noticeably, that more were willing to have their own child serve as a living donor in each scenario. more than they thought it was appropriate for the AAP to have such a policy. So here's my question to all of you. We have three groups: the AAP Bioethics, the AAP Nephrology, and the American Society of Transplant. And my question is, who are the least likely to want to allow a child to donate, and who are the most likely? So we're going to start with the most likely. Who thinks that these are the bioethicists? Who thinks that these are the nephrologists? Who thinks these are the surgeons? Yeah, well, you're all wrong. It's the ethicists who wanted to allow it. So now I got data that made absolutely no sense to me, right? I'm sitting there saying, I don't want to allow children to serve as living donors. What's going on? And we never actually, because it was a small study, we really don't know what's going on. I came up with a story, at least, which is that the pediatric bioethicists think about things from a family perspective. And so they were thinking about all the harms that would happen if a child wasn't allowed to donate and that the other child did poorly on dialysis. But I'm making that up. I have no reason to suspect that. I want to point out that the surgeons were the least likely. And when you think about it, it makes the most sense. They're the ones who are worried about the risk. If anything goes bad, when you're taking out a kidney from a pediatric donor, I mean, it's on your conscience. And so it makes total sense that they were the most conservative. I want you to know that when I'm in a pediatric audience, they know that the Grays are the pediatric bioethicists. So it was fascinating in this room that all of you gave the pediatric bioethicists that they were more concerned about risk than they really were. So are twins different? Right? So the overall data showed about a 10% difference between all respondents. But anyway, it was this data, actually, that helped us convince the AAP Board of Directors that we were not going to make an exception for the identical twins. And so the policy came out saying that living donors should, pediatric living donors should always be the exception, regardless of histocompatibility. And so now, looking back at the study, the donation by a minor is contrary to the recommendations from the U.S. Live Organ Donor Consensus Group, as well as from our AAP statement. And even though I'm showing how many said yes, and showing it between 30 and 45%, that does mean that over half thought that children should never serve as living donors. So to just conclude, well, I've actually made many of these conclusions, so I'm just going to skip to my final slide, which is just to say I want to thank my colleagues who worked with me on all of these projects. Some of them are going to be presented. The pediatric donor information is going to be presented at the AST in May. And thanks again to Chris, Will, and Dick Thistlethwaite.
Dr. Ross's paper is open for questions far.
Lainie, in the very first section, when you talked about the unintended consequences of being less living donors, it seemed like latent there is a question of whether, although we traditionally think of donation, living donation as supererogatory, not something that was put on the obligation, whether it would make sense for parents that we would think of them as having some obligation, if they're compatible, to donate.
I think all the parents would agree with you, and what they're thinking to themselves is, I'm going to be the retransplant, right? That kidney is not going to last my child's life. And while they can get priority for the best deceased donor, I should take advantage of that so that my kidney's ready when my kid needs it. So I don't think that they're, in a sense, reneging on their obligation. I think they're deferring their obligation to a time when their kid really needs it.
They're making good jobs of giving the options there they have.
Yes.
But it seems like the question that is latent there as well is whether it would make sense policy-wise, since many of those organs will last quite a long time.
Yeah, but not as long as what a 10-year-old needs.
So you think, you don't think that's ethically?
Well, no, I think the real reason I think it's an interesting ethical problem is because the new policy that they're trying to implement is this 20/80 rule, where the top 20% of kidneys defined by a kidney donor profile index would go to the top 20% of candidates, mostly defined by age. And so what we're going to see, and I don't have a slide, but if I did, I would show you that about approximately 3/4 of all kidney transplants in 18 to 30-year-olds come from living donors. And as we start giving them priority for these deceased donors, we're going to see a real drop in their receipt of a living donor transplant. And then we're going to get real numbers. Remember, kids make up a small percentage, right? They make up 5% of all the deceased donor recipients and 4% of the living donor recipients. So it's a small number. But as we start including the young adults, I think it may become a bigger problem. And it's one reason to actually oppose the 2080. It's not my main reason. I have lots of reasons for hating the new policy. But it is an unintended consequence that no one's acknowledging. And it's a really important one because UNOS can't control the living donors. And they have to realize that we're talking about almost half of all kidneys are coming from living donors.
Very briefly, if you don't do that, Lainie, isn't it the case that people who don't have the bad fortune of not having friends are going to be, they're going to miss out, even though they would otherwise get a lot of utility out of it?
It is, and that's why it's not a simple question, but I think at least we have to acknowledge the data, which UNOS has failed to do. And then if they decide to go ahead with that policy, that's fine, but realize the consequences that may result, which is less transplants overall. And since their goal is to maximize graft numbers and graft survival, it probably is going against their own goal.
So, Lainie, throughout your talk, I was trying to sort out your perspective on when to favor, in some ways, the perspective of the individual versus the community perspective. And at times, I had trouble sort of seeing if there was consistency or not. For example, in the maple syrup example, you talked about even though you might be able to serve more people in the community by having maple syrup folks use dietary therapy, you said you were inclined to say, well, they should be able to have transplant if they want. Yet, when you were talking about the en bloc example and mentioned that, well, do you divide the kidneys or not? You said, well, so the opposite. Well, probably we should divide the kidneys, and so that even those like a 7% less chance of survival benefit two people. So it seems somewhat contradictory.
So I'm going to start with my bias. I'm a pediatrician, and I really care a great deal about kids, right? So you notice I'm giving priority to the maple syrup. Remember, I'm also saying when I think we should be splitting the 1 to 5-year-old kidneys, because children get maximal choice of kidneys under Share 35, what I'd really say to them is all 1 to 5-year-olds should be done as single kidney transplants, and surgeons should be thinking about the 6 to 35-year-old kidneys that they want to be putting into their kids. So I'm consistent in that. I am totally biased in favor of children. I totally acknowledge that. But again, I'll argue that there's a real need for it in that children don't develop and don't grow and do really quite poorly when they don't have a transplant and they need it. With the maple syrup urine disease, I'm a little more stressed with that because they can do well with dietary, although if they have a decompensation, it's irreversible. And so that's really serious, and it's really hard to maintain these strict diets. And when kids get sick, it gets even harder to really get to avoid a metabolic decompensation. So again, this is my pediatric side talking. Nevertheless, so since I'm a pediatrician, so as a pediatrician, I would definitely tell a parent with a child with maple syrup urine disease, go on the liver transplant list. So it's going to require that we have policies that are going to say yes or no, or whether they get highest priority or not get highest priority. Because as a clinician, my obligation is to the patient in front of me, right? As a policy, we need to decide. If we decide we're not going to give deceased donor transplants to anyone who could be treated with dietary therapy, then I'm going to even suggest to the parents to go for a living donor transplant, right? So I don't think I'm totally inconsistent. One, I'm totally biased in favor of kids. I acknowledge that at the beginning. It's a full disclosure. But second of all, I do think that as a clinician, we have to focus on our patients, and yet we'll have to accept whatever policies we all agree on. And that's why I'm pointing out some of the intended and unintended consequences of the current policies that exist.
So, Lainie, my memory of our data is among the people electing to have their kids get a deceased donor, parents electing for kids to have a deceased donor transplant first. That's a much stronger, more frequent opinion in the African American community than in the white and Hispanic community when we looked at it by race.
Yes.
So I'm not sure that the answer you give answers completely that people are thinking this through.
Yeah. So
because that should have no racial or ethnic bias.
Maybe. So Dick's point is a totally valid one, which is when we look at which parents have become less likely to donate a living donor transplant, it tends to be more of the African Americans, and that the Hispanic and whites was slightly lower, but really minimally so. And the reason it may be is, again, when we look at the health issues within the African American family, where by the time somebody is 45, that the likelihood that they're going to have hypertension or diabetes is higher than in the other communities. And so, from their own health perspective, it may be that they're thinking, let's see if I can get to 45 and 50 and be healthy enough to give a kidney.
Yeah, that existed before also, though. Second thing is that I want to emphasize the potential unintended consequence of the new system, where you identify by who are the best 20% of recipients and give them the best 20% of kidneys, because there are four things that decide who's in the best 20% of recipients, and not having a prior kidney transplant is one of those. So someone who gets a living donor kidney transplant as an infant needs another one when they're 20 years old, isn't going to get one of those really good kidneys, so they're going to be excluded. So I think that's
another reason for parents to defer, in a sense, to let their kid get the deceased donor kidney when they do have priority.
So the third thing I wanted to ask you as a pediatrician is that we know lesser degrees of renal failure, not requiring dialysis, when you're not eligible because of a low GFR, even for a preemptive transplant, do cause growth retardation, cause delay in cognitive function. Are these, should we actually preemptively be transplanting kids who have diseases we know are going to cause chronic renal failure, but early in the course of their disease?
Wow. Tough question. I guess I would let the parents make that decision, right? And I would bet that would lead to a lot more living donors for those children who have those kidney conditions, which are going to be a slow decline and yet eventually lead to kidney failure. I would bet they would go preemptive.
Lainie, you showed us those curves on survival of organs by different age groups of the donors. Do you know if there are parallel curves in for example, liver transplant, or would the liver transplant situation show different kinds of results?
You're going to have to wait till the end of this summer, since we'll have a student doing some of those projects this summer.
So
I don't know. I'm sure there are, but I don't work. I specialize, Mark.
I'm just curious, in the calculations about maple sugar urine disease with and without transplantation, how far out did the consideration of benefit go? So, for example,
not long.
Did it consider the noncompliance of adolescents with immunosuppression and the long-term consequences of immunosuppression and the possibility of having to be retransplanted at some time?
So since we've only started doing it in the last 5 to 7 years, we don't have any long-term data, but clearly those are issues. The group that who have been, in a sense, at the forefront of this is the Amish community in Lancaster, Pennsylvania, where the special the clinic for special something is, and those parents and that that is a very tight-knit community, so that might not even help us in long-term data about compliance or anything else. So, but it's a totally reasonable point to be determined.
You have the same non-compliance with dietary control when kids actually got to that age of these diseases.
And again, with the dietary lack of control leading to a metabolic decompensation that's irreversible.
Lainie, what's the interaction of recipient age and donor age if the donor kidneys are very young? Do they?
They do well.
They do well if they get through the early period?
Exactly. Yeah, that was all, but we actually did divide it by age, and people do well. So it really is, I mean, there's probably some cutoff. The one study that I pointed out looked and said it was something around 9 or 10 kilos worth of kidney is what you need.
Will actually did an analysis of variance looking at the recipient age, and it was not that.
Okay, well, thank you very much.